welcome everybody. I'm Alan Schroeder. I'm the co-chair of this weekly seminar series on COVID in children. Really excited for today's session, which we will get to shortly. But first, text code for CME, that will go as always in the chat. In upcoming sessions next week, we are going to have another open forum with Dr. Mathew and Dr. Bonnie Maldonado. We will be taking questions. We did this probably 2 months ago and took questions in advance. And so Ingrid will be putting the link for questions in the chat. So please feel free to enter questions there. That will be on really anything that you want to know about COVID. May include some lingering questions from today's session, specifically on vaccines. Vaccines, obviously a hot topic, so a good portion of that session might also cover vaccines, but cover other issues as well. And then we are going to focus on February 11th on COVID and adolescence. As we know, the mental health struggles in our teenage kids have really been profound. And we have a group of experts from adolescent medicine and psychiatry and general pediatrics that will be focusing more specifically on that. So that's great. You can stop sharing, Roshni. Ingrid, thank you so much. And before I introduce today's speakers, I just want to set the stage for where we are right now in the pandemic. And I think there are a lot of reasons for optimism. We have a vaccine that is much more efficacious than we originally thought. We have several vaccines. We have case rates and hospitalization rates that are decreasing at rates that are surprisingly fast for reasons that aren't totally clear. Maybe we'll learn a little bit more about that today or next week, but that's encouraging. And we have an administration now that is committed to fighting this pandemic, committed to getting vaccines out as soon as possible, really embracing science, which has been fantastic. But on the other hand, we still have kids who are not in school, mostly. My 8th grader has not been in school since March, and we have concerns about variants that we're going to hear about today. And we don't really yet have any good data on pediatric immunization. So my glass is still half full. I'll be interested to hear how full our other panelists' glasses are. But in no particular order, I'd like to introduce Roshni Mathew, our co-host of this series. Roshni is a associate clinical professor in pediatrics in the division of infectious disease, and is really our champion for infection control in the hospital, and is my personal go-to for all things COVID. And I've really enjoyed being on this panel with you, or on this seminar with you over the last few months. Dr. Grace Lee is a professor of pediatrics, also in infectious disease, and is the associate CMO of our hospital for practice innovation. Of note, Dr. Lee is also on the ACIP. She'll be talking about that a little bit today, and as well as also on our governor's scientific safety work group. Pretty cool, I think, that 2 of the 11 members of that work group are from our department. And actually a third who's Nikki Klein, was a former resident. So really some great Stanford Pediatrics representation at the state level there. And then lastly, Dr. Ann Arvin, thank you for coming back and joining us again, Dr. Arvin. Dr. Arvin is a professor of pediatrics. She has recently been the provost and dean for research for all of Stanford University, is really a titan in the field of virology and immunology. Really thrilled to have Dr. Arvin back. So that's our wonderful panel for today. And Dr. Lee, I believe, is going to start by, she's fresh off of a ACIP meeting from yesterday, and is just going to share some of the findings from that meeting.
Thank you so much. And Dr. Arvin and Dr. Mathew, please feel free to jump in wherever you would like. I'm just going to run through some quick updates from ACIP. I just culled some slides. These are all posted on the ACIP website. Our ACIP Secretariat presented yesterday the state of where we are in the country with regard to phases of vaccine distribution. As you can see, 11 states are still in phase 1A, which has been healthcare personnel as well as long-term care facility residents. 38 states, including our own, is in some part of phase 1B. And there are actually 2 states that are already into phase 1C. One of the important challenges we've all lived through during the implementation period has been the differences that have been occurring by state and even by county or by health system, and the challenges that have been brought about by that. I am excited that we have a new director of the CDC, also an infectious disease physician, who I think will be able to help support and bring this country together in conjunction with other key scientific voices at the White House and at federal agencies. The second is that our state actually is rolling forward with a proactive plan to really start to harmonize some of the differences across counties and the challenges that we faced with implementation, which I think is, again, a positive move in the right direction. More to come on that soon. But just to say that ACIP, I had always intended for us to efficiently deliver vaccines and for there not to be sort of holdups at any particular phase. I'll also say that I feel pretty strongly that it's not only efficiency that matters, but also equitable distribution that matters. In terms of the doses distributed as of January 26, you can see there were 44 million doses, 23 million administered. I will say that I do think there is still some data lag between the 23 million and the 44 million, in that we know that all of that data doesn't come through seamlessly, but I think things in general are moving more quickly, which is terrific. Yesterday, one of our colleagues presented some information about SARS-CoV-2 infection in children. And what they had done is, I like this in part because what they had shown is that because there was under detection or under reporting or under testing in younger children early on during the COVID-19 pandemic, so in the earlier part of 2020, that our apparent rates of infection in children, who also happen to be often less symptomatic than adults, are probably far underestimated. And this shows that actually the 5 to 17-year-old age group looks pretty close to the 18 to 49-year-old age group when you adjust for that under detection. It's still lower in the younger 0 to 4-year age group. This set of studies talks a little bit more about transmission and transmissibility. What I, again, took away from this was that even though we don't highlight children as being as frequently hospitalized or at as high of risk of severe complications and death, they do still occur. And infection is clearly occurring, as seen in the seroprevalence study in Mississippi, showing that over time, the infection rates or prior infection rates per seroprevalence were as high as 18% by September and could be even higher now. I like this study also that they showed yesterday, which is a household transmission study from Tennessee and Wisconsin. And what this showed is that, number one, that the children are less likely to be index cases in the household compared to the adults. However, they are a significant proportion of our household contacts. And they subsequently showed that symptomatic children, so those who are the index case, seem less likely to transmit SARS-CoV-2 than adults. And I think this mirrors our experience in our pediatric facilities in general, that in fact, oftentimes we are at higher risk from each other, from our coworkers, than we are from the children that we care for in the hospital. So again, this is just a nice household study to demonstrate that in general, the older you are, the more likely you are to transmit. But that said, young children seem to be at a similar risk of becoming infected as adults. So being a kid doesn't protect you from infection necessarily. It's just that perhaps your risk of transmission to adults is lower and your risk of severe disease is lower. But again, I will emphasize, even though we talk about that, just because of the the disproportionate burden of severe disease in older adults. It doesn't mean we don't see sick kids in the hospital. And to me, it doesn't mean that we shouldn't think about prevention of infection in this age group, both in terms of what we typically see as classic COVID with respiratory disease, but also MIS-C. This is another study that just showed, again, that secondary infection rates were similar among pediatric and adult household contexts. So really important for us to think about as we're moving forward with pediatric vaccination. This slide was shared by Dr. Erbling from the, I believe, NIH, and she was part of what it was formerly known as Operation Warp Speed, but maybe Dr. Arvin knows what the new name will look like. I'm not actually sure. But I like this because it's kind of looking ahead to what we can expect in children. So we know the Pfizer-BioNTech vaccine is currently approved for children, teens, 16 and older, and also that they had been enrolling adolescents or teens down to age 12, and now they are fully enrolled. What we're hoping is that that information down to age 12 will come through when they go forward with a biologic licensing application later this spring, early summer, whenever that happens. I can't remember exactly the date that was projected. But I think for us in pediatrics, this is probably the first opportunity we'll have to start to vaccinate children, hopefully 12 and older, assuming safety and efficacy looks quite similar. They are planning to enroll kids down to as young as 6 months, but that it's really planning stages, and that's not happening, or just I think it's in discussion, but the implementation won't happen until later. Moderna has also launched what's called their Teen Cove study. So again, they have an EUA for 18 and older, but for Teen Cove, it's for 12 to 17-year-olds, which I think will be, again, another tool that we'll have in our armamentarium to be able to protect younger kids, well, down to age 12. And I anticipate, because they enrolled, or their enrollment started later, that will actually also get approved later. So this would be probably the next one up. And then the Janssen and the AstraZeneca vaccines, really, phase 3 trials in adults. We're hopeful that the Janssen vaccine will start to emerge with data in the coming weeks, we hope, to be able to take a look at that for the adult population. And they are intending to start adolescent trials 4 to 6 weeks after the results from the adult trials are released. So we're hopeful, again, that will move forward. And the nice thing about the Janssen vaccine is that this platform, this Ad26 platform, actually has been used in teens, infants, and children, specifically with regard to Ebola vaccine. So there's greater experience in using that in children with regard to safety. And then there's the AstraZeneca vaccine. And we did see a little bit of data on that yesterday with, again, intention to begin trials in adolescents in early 2021. We know Novavax is in phase 3 and enrolling, and Sanofi is a little bit further behind. This was helpful to understand, how to think about label indication from the approval standpoint. So Pfizer-BioNTech, what they had done is, added down to 16 and then added down to age 12 so expanding that age eligibility in the adult efficacy trials was, I think, a pretty efficient way to be able to at least get us to the older teen population. Moderna is doing the standalone trial focused on safety with that Teen Cove trial. And then there's discussions about expanding age eligibility in phase 2 trials for immunogenicity and safety. And Dr. Arvin can probably speak more to this, but to me, this is what they're discussing, or protocols are in development regarding these dose ranging studies for infants and children under age 12. And you can see it's a complicated series of steps where it's going to be about identifying the optimal dose and a safe dose going forward, and that it looks like it's going in a staged approach the younger you go. So it could take us a while to get down to young infants. On the variants, there's been a lot in the news on this, and I think it changes literally every day. So again, I'll look to Dr. Arvin to help keep us up to date on this. But the 3 that have been the most commonly discussed are the UK variant B117, the South Africa variant B1351, and the Brazil variant P1. And I think, at least from my perspective, I've been most worried about this particular amino acid change with regard to potential for concerns for potential to evade vaccine-induced immunity. But that said, they have at least started to test study participant sera in these neutralization assays for the Pfizer and the Moderna vaccine. And what I'll say is that while my takeaway from all of this information is that there is some potential reduction in neutralizing titers, but what that means and what the correlates of protection are, knowing that perhaps the vaccine itself produces a very robust immune response, and that it's, again, difficult to compare that to convalescent sera. I'm not exactly sure how to interpret all of this, other than to say that we're going to need to continue to study efficacy and effectiveness, and continue to do genomic surveillance in the population to know how well we're going to be able to do with these vaccines for both. The other thing I'll just say really quickly is that it's really interesting, the ChAdOx vaccine, the AstraZeneca vaccine. So it turns out their trial sites are in the UK, South Africa, and Brazil. And they mentioned yesterday that they're, obviously very eager to understand how their vaccine fares against the variants that are circulating in those communities. And at least for the UK and the South Africa trial sites that they have, that they're in the midst of where those variants are circulating. They had mentioned that for Brazil, their trial sites were actually in a different location than where the epicenter of the variant strain is circulating. So I am, hopeful that maybe we'll learn more, across all the vaccines. We're going to all be paying close attention to that. And then I just have a couple of, dosing and administration things. There's been no change in that we're still recommending 3 or 4 weeks apart for the mRNA vaccines for the 2-dose series. We're trying not to delay vaccination because obviously you're not protected until you get 2 doses. But there was kind of an upper limit placed of about 6 weeks. And this was really, again, not to say that it wouldn't count if it was after 6 weeks, but we're really just trying to make sure people are getting 2 doses in as tightly as possible in order to optimize both individual and population level protection, that the vaccines are not interchangeable with each other, that there's no product preference, but you should probably, there's every effort should be made, including us making sure when we vaccinate our patients or when you receive your second dose, that you're getting the same second dose as the first dose you got. In exceptional situations, it's okay to replace, but this is not a recommendation. It's really focused on making sure you get the same second dose as you do first dose. It's just saying you don't get a third dose if you accidentally got a different second dose. And then, this recommendation about administration alone has come up a lot, and particularly for pediatric practices. And I think that, our thinking was that we don't have any safety data for co-administration. We don't have any reason to think there would be any issues, but as we're, obviously having a ton of attention around vaccine safety, that we just thought this was a prudent recommendation to avoid confusion in case there are more side effects with multiple vaccines at the same time, so that you could just separate that out in the short term until we have more information. And with that, I'll stop, and maybe if it's okay, I'd love to hear Dr. Arvin's impressions, comments about the variant, or anything else you'd like to comment on vaccine development.
Yeah, that would be great. And feel free to jump in.
Okay, thanks very much. A really great summary of what's going on. Before I comment, I'll just mention I do consult for a company that's making monoclonals, and that's Vir Biotechnology. As far as the variants, let's focus on that to begin with. I thought, as you showed, Grace, in your slide, the recent publications, that is like within a breath ago, the companies have studied the variants looking at neutralizing activity in vaccine recipient sera. And I find that data overall reassuring, as you indicated. The reason is because what they do is they make either they introduce the mutations into the original or an original clinical virus and make a recombinant virus that expresses the different mutations singly and in combination. And so that's one way in which this is studied. The other way is by making pseudoviruses where the mutant, let's say an RBD, receptor binding domain mutation, is made and expressed in an VSV virus, a pseudovirus so-called. And that then is a platform, a mechanism to measure antibodies and neutralizing capacity in either of those or other lentivirus systems. So robust kind of layered approach to looking at whether or not these mutations allow escape from neutralization. And my reading of the papers is that the variants remain fully neutralized by serum from people who've received vaccine and at levels, at titers that are quite substantial. So this, as Grace indicated, vigilance absolutely necessary to keep tracking the emergence of variants. We expected this. I don't think it's surprising. The good thing so far, I don't think we have a signal that these variants are causing worse disease. We have some signal that they may be more transmissible, but it's all the more reason to get out there with the vaccines as quickly as possible. The other thing to note about the immune response to the vaccines is we always focus on neutralizing antibody, but of course these vaccines are inducing very useful and important antibodies that are not neutralizing in terms of protection, other mechanisms of protection. And the other point is that at least one of the vaccines we know already induces T cell responses. I'd be surprised if the other one doesn't as well. So at this point, I think we can be very confident in the vaccine rollout and the incredible value it will have if we can just get it done in a much more efficient way.
So a race of the vaccine against the variants, and it sounds like Dr. Arvin, your glass is mostly half full at this point. What is it? What is it that scares you in terms of a potential variant on the horizon that might escape a vaccine?
Well, I don't know how scared I actually am because with a vaccine, I mean, sure, we know there can be escape, but escaping all of the arms of the immune response where you've triggered that response with a vaccine, it takes a lot of mutations. I mean, we know the story with HIV, and that is the biggest of the challenges. But here, yes, we have to keep up. Now, also, as Grace mentioned, with these mRNA vaccines, it's possible, as is already being discussed, make the next dose be a vaccine that takes into account what variants there are. We don't have evidence, maybe it's worth commenting on this. We don't have evidence that these mutations have arisen under immune selection pressure. So it's not like we are creating them. The virus is just finding its happy place or whatever you want to call it. But it's not like we've put immune selection pressure on mutants. So what we need to think about is at what level of vaccine immunity could we begin to see, let's say the vaccine isn't protection against some replicating virus. Would you then select in somebody who's been vaccinated for a set of variants that would be true vaccine escape mutants? I think that is something that we know we have to watch. It's what we watch for with flu vaccines every year. Have we got a mutation that's going to make our vaccine ineffective? We do have these platforms now where we can address that. I think the other real unanswered question is what's going to be the duration of immunity to these vaccines. We see obviously, as time goes on, we will have more and more data about that. But a big question in my mind is, will a 2-dose regimen be enough? Or will we let's say next winter, have to get everyone back again? I don't know that we have a basis for predicting that. So I think that, yeah, definitely more than half full. And especially now that we have a real effort to get these vaccines out and given to people.
Well, I want to spend most of the session talking about kids, albeit, of course, with the caveat that we don't have much data on kids. But just to finish closing the loop on the general data we have on immunization thus far, there's been some debate about the one shot versus 2 shot. Do we try to get everybody 1 shot now? And I think Dr. Arvin and Dr. Lee, that one of the concerns that's often been voiced about the 1 shot approach is that might allow for more escape in terms of the virus being able to evade the vaccine. Do you share that concern? Do you think that we should stick to the 2-dose schedule as it has been studied?
I feel pretty strongly we should just stick to the 2-dose schedule. We don't know, we have some inkling that perhaps we have some immunity after 1 dose. We don't know how durable that immune response is, as Dr. Arvin was saying. All the trials were done with 2 doses. If we had trials with 1 dose, then I feel like we could comment about that. But it seems to me imprudent to make a recommendation outside what the evidence shows us, especially because I think, it really is high stakes. Dr. Arvin, what do you think?
Completely agree, certainly. And I think that the idea, as you mentioned, of allowing a 6 weeks window, that makes perfect sense. And for all we know, it is fine to make it a 6-month window, but we do not know. And our goal is to control this epidemic. We should not be inventing strategies without data and science behind the data. Now, I will say one thing, one of the committees I'm on is the NIH active so-called vaccine working group. One of the topics we've been discussing in the recent meeting is immune correlates. So this is relevant in a couple of ways, but coming back to your point about kids, I am hoping that with the vast amount of data that has been collected from the studies in older people, that it will actually be possible to define some level of antibody response that does correlate very strongly with protection. Now, when we say correlate with protection, I want to emphasize that doesn't mean it's the mechanism of protection. The way the vaccine may protect people is likely to be multifactorial, as we were talking about, different types of antibodies with different functions, the important T cell response. However, if you've got a big enough database and you've got enough breakthrough infections, that's what you really need, of course, is to say, well, was there a definable threshold? And if we can do that, which I'm cautiously optimistic, then I think we can make the pediatric studies, and Grace will know how ACIP is talking about this. The ACIP may say pediatric studies can be done as bridging studies based on an immune response that is defined as a correlate of protection. That will make our task of getting the vaccines ready for children much easier. And I think a very legitimate, scientifically grounded way of doing that step in extending to kids.
Let me just make sure, just for our listeners, and Dr. Maldonado has brought up bridging studies on this session as well. Basically, what you're saying is that by rather than randomizing kids to getting a vaccine or a placebo, we just give the kids a vaccine and assess their safety, of course, but also assess what their immune response is to the vaccine.
Exactly.
Yeah. So let's get back to kids in a second, but just to make sure we've covered everything with immunization, and I'm seeing a whole bunch of questions that I want to make sure we get to a lot of the participant questions as well. One of the other things that continues to surface as an unknown, slightly different question, but still related to the vaccine, has to do with transmission and whether we feel that individuals who are vaccinated can still transmit. And Dr. Lee, did that come up on your call? And for both of you guys and Dr. Mathew as well, your thoughts on that and how comfortable we can feel that we will not be transmitting virus if we have been vaccinated.
Dr. Mathew, why don't you go first and then I'll chime in.
Well, I think you have the most up-to-date information, but as far as I know, Moderna, I'm sorry if I got cut off in between, but Moderna vaccine studies, the trial did assess asymptomatic infection following vaccination, and they did show that there was a reduction between the individuals who got the vaccine versus the individuals who got the placebo. So I think we have a little bit of information, but as I understand it, it's not enough for us to be confident that that is the case, that vaccination completely eliminates the possibility of asymptomatic infection. Did I get that right, Dr.
Yeah,
Lee?
absolutely. And I was just going to say, and so I know what Dr. Mathew would say is we still have to adhere to masking and social distancing and all the important public health measures that we need to continue. I'll just add that, yes, the data were scant. It was actually really helpful to see that preliminary data. All of the trials have really focused on symptomatic COVID-19 disease. A few of the trials have had as secondary outcomes asymptomatic infection. But to date, I feel like we still need additional information on that. And some of it, I think, will come from the trials with what information they did collect. And some of it will come from longer term studies. The only other thing I'd say, well, Dr. Arvin, it looks like you want to jump in, and then I'll say one more thing. Oh, okay.
I was just going to agree with you. We don't have the data agree with both of you. I do think we have, from experience in other vaccines, reason to believe that transmission will be impacted. Simply just thinking about the data you showed in that from the household transmission of actual infection, the fact that the kids were infected, but less transmitters, if you will, speaks most likely to a lower viral load in those kids in respiratory secretions compared to the adults. And we would hope that we don't, I think it's really not expected that you would block any low-level replication potentially occurring due to vaccine immunity. We don't see that with natural immunity to many different pathogens. So it's, I think it's important to know exactly what the information is, and we'll get it, but it does not, even if we show, let's see whether colleagues agree, even if we show there is some virus replication in people who've been vaccinated and then exposed, are we going to say that we're all going to wear masks forever? I don't think so. I don't think it's going to lead to that conclusion. We're going to be looking at impact on disease and severity and outcomes more than we are going to be focused solely on whether it's possible to transmit despite vaccine.
I mean, it seems like there's sort of two questions. One is, how likely are you, if you're immunized, to find virus in your nose? But then the second is it going to be enough virus to make it from your nose to someone else's? And that, yeah, it seems like we have a little bit of data on the former, but really none at all on the latter. So any sense for when we might have that type of data? I don't know, Dr. Lee, if that, your sense for whether that's on the horizon?
Yeah, it depends on the vaccine specifically. You know, I know that Moderna was collecting at least some information, and I should be clear that that was between dose 1 and dose 2. So we don't know after dose 2, you know, what the impact is. I 100% agree that it would make common sense for there to be a reduction in transmission or transmissibility. And is it enough to, you know, bring the R naught below 1? Our hope is that yes. Is it as good as 95%? I don't know. It's hard to say. So we'll learn more as we go. I do know that the AstraZeneca vaccine, so that published trial did have more information on that to me looked less promising, but we'll dig more into that as that comes closer to approval in the US.
I'm going to just intermittently take some questions from our participants. And this one, the first one I'm going to read is on sort of the concerns about side effects and immune response, but specifically asking actually, if you didn't have side effects, does that infer that perhaps you did not have enough of an immune response? Anyone want to try to tackle that?
No, it's not.
Yeah. Agree. I mean, basically, like, the trials show 95% efficacy, 94% efficacy, and the vast majority will have it. The framing is really expect it because that's your body's response, or that's your body developing an immune response. So it's okay to have local and systemic reactions. So don't fear it. But on the other hand, it doesn't mean if you don't get it, that it's a problem, because we know it ends up being, 95% effective.
Right. Yeah. So, Dr. Mathew, I'm going to go to you now, because I think when we talk about pediatric immunization, obviously the risk-benefit profile is going to look different than it does in adults, because kids have not had nearly the burden of severe disease. But as Dr. Lee mentioned in her slides, the burden is not zero. Can you just give us a sense? You've probably taken care of, or at least been involved with more kids on the hospitalized side than most of us. Can you give us a sense, both numerically and from your own experience, what the burden of disease is in kids as we know it, and why it's important to prevent that?
For sure. So the hospitalization, so we've had many kids who have been hospitalized who have had a positive SARS-CoV-2 testing. From our experience, it's about 60% of them, however, were admitted for other reasons. So they could be from appendicitis or a fracture or some other chemotherapy, some other reason, but they had a positive test. And then we've had about 40% of the patients that were admitted because of COVID positivity. But again, among the patients that were admitted because they had a COVID positive test, only a small number of those patients had severe disease. So this would definitely be different than the adult population, where a vast majority of their patients are admitted because of COVID, and a lot of them do get very, very ill. So our experience has been that children do not get that sick. And some of the comorbidities we have seen, like obesity, definitely seems to play a role even in children, and we've seen that in older teens. But again, as Dr. Lee pointed out, it's hard to sometimes guess who the child is that's going to get really sick. And the MISC is another completely different, another entity that we have no idea who gets MISC in the end. So I think we've had a fair share of that as well. So that's been the landscape of our inpatient admissions.
We have heard so much, and we're so sick of the flu COVID comparisons, but just for context, what is, for all three of you, if we had an immunized adult population, but we still didn't have an immunized pediatric population, how would the burden of disease compare to a standard influenza year?
I can go first, maybe take a stab at it. I think, well, children in the United States constitute about 75 million. So that's the population of children less than 18 years of age. And with Dr. Lee's more recent updates from ACIP, that children can have much more infections than we knew of, I do think that if we only immunized adults, there would continue to be a burden of disease my sense is we would not achieve herd immunity if we completely exclude children, but that's just my mathematical calculation. I don't know if Dr. Lee and Dr. Arvin, you have other thoughts.
I mean, I agree. Every year we forget this because, we just kind of live with flu, but every year there's at least 100 pediatric deaths from influenza, and half of those deaths occur in kids without any high-risk medical conditions. So to me, why do I vaccinate my kids with flu every year? It's because I want to be able to have every tool in my toolkit to be able to protect my kids. And so I make that choice, even though I know the risk of death is extremely low in children. It doesn't mean it doesn't happen. And it happens, without rhyme or reason sometimes. I feel the same way about COVID. And in fact, the deaths, number of pediatric deaths from COVID is higher than we've seen with flu, in part because the burden is so high. So it seems,
and that's in the face of a lot of restrictions, which we don't do for flu.
Right. So I feel like we're going to need that tool in our toolkit to be able to protect our children. And, I feel the same way in that it's important for us to be able to prevent a death. And that's what vaccines are there for. And if we can prevent a death or prevent a case of MIS-C, to me, certainly on an individual level, it seems worthwhile.
So oh, go ahead, Dr. Arvin. I was going to ask you a question, but go ahead and then I'll ask you the question.
Well, I was just going to echo what Grace and Roshni have said. And I think another example is, why do we vaccinate against chickenpox? I have a considerable experience beginning when I was a fellow with the introduction of that vaccine. And it was about the question you've both touched on, that we can't predict. And we know inevitably in the case of varicella, there'll be 150 or so deaths every year in children who were perfectly healthy, and we didn't have a way of predicting. And so I think there's a strong case to be made, for the reasons that you've mentioned, to vaccinate kids for their own sake. It is an issue that where you can evaluate compared to flu, but compared to many other pediatric vaccines that we give. And that to me is the primary reason for vaccinating kids. I also agree that we aren't going to get on top of the pandemic if we don't vaccinate kids. So I think we have to get there soon. I wouldn't say that we won't get on top of it in a very important way before we vaccinate kids, but that has to be the next step. And I think we'll see that the companies will move forward. It was talked about, this question was talked about from the very beginning by the working group. And I would have to say that the pediatricians on the working group are the ones who kept having to say, we need FDA requirements for plans to vaccinate children, and not just after everything is all tidied up for the adults. It needs to happen sooner rather than later. And I think we are beginning to see that happen. I think having more alternatives for the type of vaccine will be really good. So maybe we will be able to use one of the adenovectors as a vaccine preferentially for kids. But I think it is really important to move those studies along as fast as possible.
I want to follow up, and just to the participants, thank you for all the questions. I am not sure we're going to be able to get to all of them today, and there is a feature on the Q&A where if you hit the little thumbs up button, then I can make sure that we try to get to questions that are of most interest to the audience. So please take advantage of that function and scroll through the questions. But Dr. Arvin, I know that you have, one of the questions that comes up on this forum a lot, it's certainly a question I had early on, is given that MIS-C is a delayed immune response to the viral infection, is there a concern that the vaccine would trigger a similar response? And you've looked at vaccine enhancement, talked about vaccine enhancement before, but how much does that concern you at this point, and when will we know?
Well, I think it comes back to what was said earlier. If we don't have evidence that there's really an let's say antigen specific immune response that triggers MIS-C. We don't see at this point in the limited studies and data we have so far, we don't see that it's related to some aberrant antibody or T cell response. We don't really know what triggers it. There is some small evidence of autoantibodies that may have been induced by the infection and create inflammatory problems later. There are just too many hypotheses, but right now I would have to say that adaptive immunity is not emerging as being somehow different in the kids who get MIS-C from the ones who have mild infection. Too soon to be sure about that, but I think our experience is that all of the adverse consequences of infections, whatever the list might be, our experience with vaccines is give the vaccine, and that's the best way to get rid of all of the post-infectious complications that we observed. I mean, take cerebellar ataxia after chickenpox. We never knew what caused that, but if we vaccinate, we don't see it. So I think we have to do our best to understand the mechanisms of MIS-C, but at this point, I don't see it as a reason not to vaccinate. I would see it more as a reason to vaccinate, but I'm eager to hear what Grace and Roshni would say.
Well, I was just going to say, when you're answering that another one of the questions that's come up is about long COVID syndrome in kids. Another sort of thing that's not measured currently when we talk about the impact or the morbidity, but is there MIS-C is caused by the virus itself. Long COVID could be caused. We don't really know. So lots of things that we're preventing beyond just pediatric mortality. Dr. Mathew, were you going to say something?
No, I was just going to agree with everything Dr. Arvin said. Yeah, exactly for that reason. We just don't seem to understand what is the risk profile for development of MIS-C. And so, and we know that the children can get very sick. So another reason to vaccinate. So I agree with that.
And for the question itself was, are we actually seeing mild or asymptomatic infection causing long COVID? And to my knowledge, there's not a ton of data on that. There's been lots of anecdotal stories, including some stories in the New York Times. But have you guys seen much in terms of good literature on that?
No, I mean, I think that, I'm hearing anecdotes for sure, that of course in the adult population, but I'm starting to hear them now in the pediatric population. What I would say is that, to date, we're going to need to expand our measures of success. So we've been very focused on hospitalizations and death. Those are very tangible and easy to measure. But I do believe that in order to capture the full benefit of vaccination programs, we are going to have to start to think about how to capture the benefits from protecting against the long-term sequelae associated with COVID-19 infection, which includes MIS-C or MIS-A or long COVID syndrome. However that's defined.
Another uncertainty there is we had a whole session on COVID in the heart, but concerns about potential subtle impact on the heart, and we have not certainly seen a surge in sudden death in kids, but also kids haven't been exercising as much as they were, sadly. There's a question about the impact of antipyretics and anti-inflammatory agents given in conjunction with the vaccine. That's a very common question. Do we worry about taking the side effects are not uncommon, fever, chills, aches, those sorts of things. Are we dampening the immune response with Tylenol or Motrin?
Well, I'll just say that we've gotten this question at ACIP. Our recommendation is not to prophylactically give Tylenol or Motrin. But obviously, if you're uncomfortable, sort of, a couple days after you get the vaccine and you're having some significant reactogenicity, that it's fine to take it. But I would not advise prophylactic Tylenol or Motrin. I mean, it's all theoretical from my perspective, but I also just don't see the need to do it prophylactically.
Yeah. A couple questions have come up about I know there was a vaccine, a death in a physician in Florida. That I believe that case was a physician had ITP that developed, I think, 3 days after the immunization. So it seemed quick to be attributable to the vaccine itself. But and then I am seeing a link here that someone's asking about a new vaccine-related death in Placer County. I'm not aware of that one. I'm not sure if you guys are, but maybe talk a little bit about the expectation that we're going to see, certainly because so many people are being vaccinated, we're going to see lots of, sort of deaths that are occurring naturally anyway, but that might be attributable to the vaccine.
Yeah, I'm happy to take this one on. I'll just start out by saying that for the full explanation, I typed into the chat box that it is definitely worth going back to the ACIP meeting from yesterday and looking at the recording. I co-chair the vaccine safety technical subgroup, and actually we did specifically focus on not only the overall data we're seeing from the vaccine safety systems to date, but also specifically deeper dive discussions around anaphylaxis and death, given the concerns from the media. In summary, what I'll say is that the information we have from VAERS, you'll have to remember, is passively reported. So it's people reporting into the system. The other key point I'll just mention is that, COVID-19 vaccines protect against COVID-19 related mortality, but it does not protect against all-cause mortality. So as an example, in phase 1A, we have focused our efforts on protecting those who we know are at high risk for severe disease and mortality, like long-term care facility residents. And so because VAERS does not determine causality, it just seeks any reports coming in for any reason, whether or not it's related to vaccines. It does require sort of some additional contextual background rates to be able to understand what that information looks like. I personally think that while VAERS is extremely helpful for identifying signals early on, that we need to look at large linked databases to make sure we understand what the background rates of sort of any adverse event are and how it compares. So I'll just pull up the example yesterday where they brought up this question. So they did some calculations, for example, on background mortality in long-term care facility residents. And during that same period of vaccination, they expected that there would be 11,440 deaths among long-term care facility residents following vaccination, just by chance alone, independent of vaccination. And by comparison, the number of reports into VAERS was 129. And so, obviously there's underreporting into VAERS, but also the VAERS reporting that comes through is something that does not at all look like that it's any different in terms of what we would expect or anticipate. So my long-winded way of saying, please look at the full discussion yesterday, because it actually took us about 45 minutes to an hour to get through that discussion in a rigorous way. And I'm not doing it justice in the 3 minutes I just gave it. But do want to also emphasize that, number one, I think it's really important as clinicians that we report all any potential adverse events, whether or not you think it's related, into VAERS, because it's extremely helpful as an early warning system. But the second is that, I know that media reports can cause a lot of concern, but it's really important to think about the context, and we will continue to look at this and monitor the safety of vaccines. But there does not appear to be any differences or clusters or concerns that have been detected in the data we've seen to date, but we'll continue to monitor.
Great. Well, that's very encouraging.
Could I ask Grace a follow-up question on that?
Of course.
One concern I have is that when we do start vaccinating kids, do we have sufficient baseline data on the rare kinds of events that occur in kids, vaccine or no vaccine? I know it's been a problem in some of the situations with adults, what's our background rate of Bell's palsy, those kinds of questions. Do you anticipate that we have enough of a database from other pediatric vaccines that we can cope, if you will, when something untoward happens?
I certainly think so. So the ones we tend to rely on are the Vaccine Safety Data Link, and our colleague Nikki Klein actually is one of the principal investigators of the entire project, but also specifically for the COVID-19 Vaccine Safety Project. She's one of the two. So yes, they have had a long history of monitoring vaccine safety and background rates of adverse events since 1990. So there is sufficient data in my mind to be able to at least have a starting point. Obviously, VSD only covers about 12 million people. So we always want more. The FDA has put forward another system called BEST that they're hoping to leverage and use. And then, for the older adult population, actually, I realize this won't apply to us, but CMS is going to be a significant data source for the older adult population to understand background rates of both neurologic, allergic, immunologic adverse events, or events, I shouldn't say adverse events, that occur in the background, so we have better comparisons. That said, it's really confounded this year because COVID has impacted the way we seek healthcare. So it actually muddies the waters a bit, but our safety investigators have been extremely creative in thinking about appropriate comparison groups that will give us meaningful insight.
And we've got that for the, let's say, the 1 to 12-year-olds.
So VSD covers down to age 0, yeah, since birth.
And sufficient numbers.
It'll never be in the numbers. We always want more numbers, but
Yes.
as the Kaisers are actually fairly, 12 million is pretty reasonable, but you're right. Under 18 is probably, I couldn't guess actually well offhand, but in my head, maybe 1 million or so.
I'm concerned about it because as pediatricians, once we start doing vaccines, we know there's going to be background events occurring. And I hope we have good data sets for reference to
right.
try
Well,
to
the one
sort
thing I
through.
can say is the background rate of MIS-C before COVID should be 0. So that's the only one I can speak on.
No, I'm not saying that. I'm not talking about those. I'm talking about something that isn't COVID related, but has just occurred in
right. The background rate of diseases in kids, which I would agree with you. Kaiser's as good as it gets in terms of having that type of knowledge, but. And it's why, Dr. Arvin, why randomized trials would ideally be done, but I think to help tease some of that out. But
yes, clinical trials always help.
I want to just in the last couple of minutes. One of the questions here that is actually very almost identical to a question that I had prepared in advance anyway. So let's make sure we cover it. And it's about schools and the extent to which immunizing kids should be required to get them back to schools. I have a strong opinion on that, but I'm interested to hear your guys's. So teachers are vaccinated, presumably. Do we need to wait for kids to be vaccinated to get them back to school?
No. I'm pretty open. Sorry. We have seen schools effectively reopen now without vaccines. It's obviously easier to do when you're talking about elementary school than it is high school because of the way that we deliver education. But we have seen in our country, for example, so there's a great study that was just published in Pediatrics recently. I think it was Pediatrics about the UNC and Duke experience. And actually they demonstrated that the kids who were in schools had lower rates of infection than the kids who were educated at home. So I have to say, I think that it is very much like healthcare, everything's about mitigating risk. And so our job is to help, our workplace to be a safe workplace. And that's what Roshni does full time and beyond. And also, I think if we can create a safe school environment, vaccines are essentially another layer of protection that just goes, that creates additional assurance. But that's why I also think that we're not going to pull away the other layers of protection for a while until we really truly have vaccines for the entire population. And while we'll continue to need to use tools like social distancing, masking, screening, all those things are going to continue to be important until we can protect all the population. But
all right. Well, I'm
very
going
safe in Roshni's hospital. What do you think?
I'm going to take the liberty of speaking for Dr. Mathew and Arvin, and because I'm seeing nodding heads. At least 4 of us agree that kids should be back in school as soon as possible. I know Dr. Arvin mentioned that beforehand too. I want to take 1 or 2 more quick hits here. And I don't know if this is a quick one, but we'll try. When might there be studies comparing the antibodies produced by mRNA vaccines versus adenovirus vector vaccines? Oh, you're muted, Grace.
I think I'm talking to myself. I'm hoping Dr. Arvin can answer.
It's always a problem, but I can tell you one thing is that there was a concerted effort at the beginning of all the vaccine program and development to create a biobank that has samples from multiple different cohorts. Now, that will, I think, be really important. The other thing that is, of course, quite possible is once you've been vaccinated out of a study, you can go and participate in any research project you want to. And in fact, we have groups at Stanford that are looking at vaccinated people who are just plain old vaccinated people, not part of a study. So once you get beyond the study circumstance, I think it will be pretty straightforward to collect representative serum or PBMCs as well from cross-section of vaccine recipients. So I hope we'll get it out of this biobank effort, but it can be addressed, and I think your point is good. It is important to address these questions of comparison of immune response. The real story for vaccines, though, is always what is the impact on disease and protection from disease. We can measure many, many different things, and it's all interesting, but it's really the epidemiology that tells us what we need to know.
We're gonna do one last question because I think it's important enough to go over, but I'm gonna ask our participants, I apologize if we didn't get to all of your questions, but in the chat function, there is a link to a Smartsheet app that you can enter your questions there. We'll try to keep track of the unanswered questions here as well, but we'll be back next Thursday with Dr. Maldonado, who last I checked knows her vaccination information pretty well, and Dr. Mathew will be on that as well. But I want to just talk about pregnancy because that's coming up. I'm hearing that on NPR all the time. Dr. Lee, I'm guessing you guys have discussed this a fair amount at ACIP, but can you just give us a quick synopsis of vaccination during pregnancy?
Sure. So, first of all, because we vaccinated a lot of healthcare workers in the early tranche of vaccines, there have been a large number of women who reported vaccination into VSafe. And so, the VSafe team actually is now creating its own standalone pregnancy registry so that they can continue to follow these women who, chose, understanding the benefit risk of vaccination, that it made sense for them to be vaccinated given they were concerned about their risk of infection. The second is that we know that pregnancy itself is associated with significant morbidity and mortality. So it is a risk factor for severe disease. The third is that our colleagues at ACOG and SMFM have come out with, actually, I've really appreciated their input on this during the entire deliberation process, because what they wanted to make sure is that we didn't limit access by saying that pregnant women couldn't get vaccinated. So they really said it should be an individual decision that women have with their obstetric provider, and that if the benefit risk balance makes sense, to go ahead and do it. You're probably asking, and I saw in the chat, there was a question about WHO and the comments. I didn't look deeply at the specific statements, but I actually don't think that those statements are any different. I think what we're all encouraging is that women should have access to vaccine. Pregnant women should have access to vaccine, number one. We shouldn't say it's a contraindication because you're pregnant, because we know that they're also at high risk for severe disease. Number two, that it should be a conversation they have with their obstetric provider so that they understand the benefits and the risks and what's known and what's unknown. And then number three, I think that, at least in the early waves of vaccination, as we focused on people who have to come into work to do their job, be they healthcare personnel or frontline essential workers, that we want to be able to give them the opportunity to be protected. And our OB colleagues have been extremely supportive of that and wanting to make sure that, again, we make it accessible to pregnant women. But again, the decision is up to the individual with their clinician. Does that answer your question?
Absolutely does, and a wonderful summary, and really nice to have such experts on this panel. I've learned a lot, and I hope our viewers have as well. So thank you guys so much. I hope we can do this again. as the vaccination continues to unroll over the next few months. But thank you very much, and enjoy your days, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.